So with this, we're gonna continue the program, and our next speaker is, as advertised, Moritz Thiel, who's gonna continue the discussion, perhaps on following up on what Vladimir was talking about. So we're going back to the clinical issues. Moritz, title is Broadening the Phenotypic Spectrum and the New Treatments in GNAO1.
Yeah, thank you very much for the introduction, and thank you that I can speak to you today. Thank you to Bow Foundation for inviting me. I'm really excited to be here today and to talk about this and to present to you my topics. So, as said before, what we have seen, I'm going to talk about the broadening of the phenotypic, so more clinical aspects now, and the new treatment options, how we are going to set it into the clinic. But first of all, I want to go to my methods. So in 2019, we started a registry in Germany for GNAO1 associated disorders, including all the German patients, and we started with a retrospective analysis in 2022. And as Giovanna told you already this morning, we'll launch the natural history study starting this year. But the good thing also coming from the registry is that last December there was found the German Patient Association, and it's called GNAO1 Gemeinsam nicht allein, what translates really to GNAO1, together we are not alone, but it fits perfectly with the first three letters of GNA. So what's really nice, and they were really supportive in all I'm going to tell you now. And Simone already told this the same, but I think that's the biggest method that we all are using and why it's so great that we are all here and also all the families are here. It's our network, and without this network, I think we wouldn't understand the broadening of the phenotypic spectrum, and we wouldn't get to the new treatment options. And so without this network, my talk wouldn't be possible. I'll separate my talk into two parts. So first of all, I'm going to talk a little bit about Parkinsonism in GNAO1, and afterwards I'm going to present my zinc trial to you. So this video has already been shown to you. I'm just going from the clinical side a little bit, how we as clinicians have this approach to the patient. So this patient was first presented to us when he was 9 years old, and for me it was the first patient with this kind of mild phenotype, just showing hypertonia and symptoms of Parkinsonism, including bradykinesia, postural instability, and a small shuffling gait. And he had some symptoms of dystonia with a striatal toe, sometimes when walking and toe walking, and also this retro and lateral collars that you have seen. Now you see the bradykinesia, that's his normal speed of eating, it's not slow motion, and he was severely dysarthric. He had also a history of neonatal seizures, then he was seizure-free until the age of 7 years, and is on valproate acid seizure-free again. Interestingly, when he had fever, he had some dyskinesia, what we all know in GNAO1, but without fever, he didn't show any symptoms like this. Here's just an overview of the testing. So in the gross motor function, he was really doing quite good, and the level of dystonia was quite low. And then, as a clinician, of course, we are asking us, are there similar patients? That's the first question. And how was our approach? And yes, indeed, there was one similar patient, as already said before, that shows really similarities. And this is what we're doing as clinicians. We build groups of patients and see what are the similarities. And then we go to the basic researchers and ask, can you help us? Why is this like this? And here you see just the difference was maybe the speech and the onset of seizures, but the rest was quite the same in these two patients, including the variant that is that is the N terminal of the G alpha protein. And this I can skip because Vladimir already showed it perfectly why these two variants are so unique in G alpha O. So I can just go over to summarize already the first part. So these variants, and I think that's how we can go on with different milder phenotypes. We should group them and see them biochemical and analyze them and see what's the reason and get to the symptoms afterwards. And in this special two variants, we see that lead to Parkinsonism, that this is also the loss of this heterotromer formation that is really important. So, new treatment options, I think that's one of the most important topics for parents. What can we do? So I'm going to start to show you the first patient that we have treated with zinc. So you have seen the flies were reacting very well to the zinc and showed enormously improvements. And I had one patient in my cohort with a very severe phenotype. So he had the 203 mutation, and he had daily dyskinetic crisis. He was really polymedicated and nearly sedated all day. And he had recurrent infections, would lead to hospital admissions, and at the end he led to palliative care, and he was sent to hospitium. And we offered the parents also, he was only 3 years old, we said, okay, we'll give him DBS to get him out of this continuous repeating dyskinetic crisis, but the parents said, okay, it's a palliative situation, we don't want it, but can you offer us something else? And knowing about the flies model, I said, okay, we'll try the zinc. Yeah, we'll try in this scenario, we'll try the zinc. And I started with 50 milligrams per day zinc acetate in this variant. For further details, as said before, Vladimir can read hopefully next month in the journals. And these are the results, what happened to this patient after 8 months of treatment. So what we have seen is there is a real reduction of the Berg-van Massen dystonia rating scale by 46 points, and the abnormal involuntary movement score as well went down, and the dyskinetic crisis, the daily dyskinetic crisis, which was so disturbing and lead to more medication, stopped as well and were reduced enormously, and therefore the emergency medication could also be reduced. The therapy was well tolerated. The parents did not report any problems, any side effects of this treatment. And most important for the parents, he started to smile again. They said we could reach him more, and we could stay in contact with him. Anyhow, there were no improvements in motor skills. Of course, it's a short time that we see the patient. This is the published data, so now he's under treatment for 1.5 years, and I can tell you he had an RS virus infection, and he could stay at home. What was for the parents the first time that he had a severe infection and didn't need to go to the hospital because he could be stable at home and had no dyskinetic status in this case. So with this first patient, we decided to go to the next step and to go for a clinical trial. Of course, it's a pilot trial. Now it's getting a little bit more into details with clinical studies. So at first, you need some pilot trial to test feasibility and safety of a new drug, because it's a first-in-human trial. So we have to prove that zinc, even it's a medication that is used in different diseases and is also approved and shows really good effects and no side effects. We have to prove that this is also the case in GNAO1. So here you find the clinical trials registered, and in Europe we have a new system since this year for registering trial drugs, and I can just recommend to go to this link. You'll find it. You can download really everything from this page. You can inform consent forms. Of course, it's in German, but all the other parts are in English, and you can find all the details. But now I'm going to show you some details. First, I want to show you my primary and secondary endpoints of this trial. So the primary endpoints, as I said, because it's the first in human trial, is safety and feasibility of zinc. Yeah. And the secondary endpoints are, as we discussed in this morning, the motor skills, the level of dystonia and dyskinesia measured by the, to date, best known measures that we have as clinicians. And the parents are given a diary that they have to fill out every day for epilepsy, of course, but also for the general behavior, for the time of sleep, for the time the patient has dyskinetic movements, and they have to rate the day every day, so that we can see if there is a subjective improvement as well. And this is just an overview of the trial design. So we'll try to include 12 patients in this trial. There will be 3 visits in our center, and the zinc taken for 6 months in this trial. There will be 2 phone calls. So the first phone call is, of course, after the start of the medication to ask for side effects when they take the zinc. So what can be a side effect is normally that they feel sick or leads to vomiting. That's a known side effect. And if they didn't experience any improvements after 6 months, they would stop at the last visit in the hospital, and then we would call them 1 month later to see if side effects occurred after they stopped the zinc. That's why we need the second phone call. In the 3 visits in our center, there will be done blood tests of copper, ferritin and zinc. Zinc, of course, to see if the level of blood is increasing with zinc, and why do we need copper and ferritin. Copper and iron are, if you ingest them, are taken over the same transporter in the gut. So if you take a lot of zinc, it's possible that the body has a lower level of intake of copper and iron, and therefore has some lack of it. And to see if there is a lack, we need to test this as well. And of course, we're doing the clinical examination, scoring, hand out the questionnaires, and do the stool samples for microbiome analysis in Vladimir's lab. So, what about the dosage? There is a good model for dosage that we adapted our trial to. So it's the Wilson disease. It's a copper storing disease. So the body can get rid out of copper, to say in easy words. And in Wilson disease, the treatment with zinc, as you understand now, it's the same transporting system. If you take zinc in Wilson disease, copper is not taken in. That's why it's done in the Wilson disease, and we adapted our trial in questions of dosage to this Wilson disease. What we done differently is that we would like to start to treat our patients before the age of 1 year. There in Wilson disease, it's 1 year and older, and we'll have this dosage. And of course, now the question is, how do we finance such a clinical trial? Because clinical trials, as in the US and in the EU, are really very strict in things you have to do and to adapt it. And I had the luck that the parent financed this first trial, and they launched a big GoFundMe assessment to get to this money, to the crowdfunding. And I can just thank them that they did a really great job and gave me this amount of money that I can start to do this trial. And yeah, this will be followed by just my summary. So what we'll expect in the future is that the phenotypical spectrum will further expand with milder phenotypes probably. And you should consider GNAO1 also in hyperkinetic patients, not only in the hyperkinetic patients. And as you see, the biochemical evaluations of different variants or groups of variants can lead to understanding us the genotype-phenotype correlation overall. And the zinc GNAO1 is the first pilot trial of treatment in humans in GNAO1. So what's the future perspective? Of course, this is a pilot trial, so it's just the first in-human trial with zinc, and if it's safe, a bigger trial has to follow. So there needs to be compared, maybe double-blind or to a historical group, and maybe it needs to be placebo-controlled. As Vladimir told before, zinc is not the solution, probably. We don't know. We will see how the patients will react for all the patients. So what is important in the future is that I think one of our focuses for the future should be this drug repurposing, to test different drugs in GNAO1 that are already on the market. But the question that comes alongside with this is, how do we finance these trials in the future? Because this is really a next step. It's great that we get there with GNAO1, but this is a question that we have to, and a major job that we have to focus in the future. And now I'm very happy to answer all your questions, and thank you very much.
Thank you very much, Moritz. This is very exciting. Questions?
So back to that patient that tried zinc when he was in crisis.
Yep.
How long did it take for zinc to kick in and see the results?
This is a question that I've been asked before. So the parents report that of course, it's a little bit different. It's not like they're taken and at once it was better, but they said they could see improvements in 3 to 4 weeks after they started zinc. So this is also maybe more to our understanding. It's zinc is kind of needs to reach a higher level to get to the brain. At least that's our understanding as clinicians. So there's the blood-brain barrier that needs to be increased. So you surely need quite a high level of zinc in the blood that is going into the brain.
Thank you, Moritz, for the discussion. It's fantastic. What about, is there any distinction between children who've had DBS and also for young adults? Is there any distinction? What age group are you going up to
Yeah,
in the study?
I didn't put in the inclusion or exclusion criteria for the sake of time. I'll include all patients until the age of 30 years. So I'll also include adults. And there is no limitation in this first because it's really to prove safety and feasibility, or if DBS is already in the patient done or not. It's an exclusion criterion if you get DBS while the trial. So if you have a planned DBS in this 6 months, you can't be included. And if the DBS was in the 4 months before the inclusion, also not, because this is of course a major change in the whole system of the patient. So we want to have the patient stable for about 4 months. Of course, they are not allowed to take zinc before included in this trial. And if they are stable in DBS settings and in the medication, they can be included 6 months to 30 years. No, actually, that's also a question of financing. It's for the moment, it's just a monocentric trial, monocenter trial in Germany. Yeah, we maybe hope to include a second center, but we're not sure yet.
I had a question. Our son's 24 and he's been taking zinc for a few years, but he's probably on about 40 milligrams a day. They do monitor his blood occasionally to see what the zinc levels are. So I'm wondering, are you looking for just a typical zinc level in the blood? And is there a danger? So I think from what I read, I thought you were looking at about 150 milligrams per day. Is there a danger to too much zinc consumption?
Yes, from the literature, yes, there is a possibility that you get overdose with zinc. Yeah, and the limits for I think Vladimir can answer also this question very well from the mouse model. The levels that we are giving here is much under. It's very safe level. So we could even get higher, but of course, the most important thing is that it's safe for the patients. Yeah. What could you expect if it's getting too high with the zinc? So mostly it's that the body is getting loss of copper, as I told before, and you get anemia because you don't have the iron. And if you go even higher, it's a toxic for the brain. So in this is, of course, it's very important to monitor it. But I think, or we have discussed this before, that probably in the treatment, you should go to the possible highest level of zinc that is not toxic, because it needs to go into the brain.
And to that vein, when you say you're going to measure copper, are you going to measure 24-hour urine copper or just a spot copper?
Actually, we are going to measure the spot copper. We discussed this with our pharmacologist, and they said, okay, for this, it's probably enough, because it's quite well tested in Wilson disease, and actually with this dose, we don't expect that they'll get a lack of copper.
Okay, and obviously this is the first step, in the logical first steps of this. Has there been any talk about whether or not it would, if this doesn't work, should we try intrathecal delivery?
That's a very good question. I'm open to this, but maybe, yeah, I can't answer this question. It's a possible next step, yeah.
Moritz, if I can ask a question.
Of course.
So on that patient that you treated with zinc, have you checked the blood levels of zinc prior to initiation of treatment? And what about the plans of doing this in your clinical trial?
Yeah, we've tested the zinc level in this patient, and it increased a little bit. I can just maybe switch back. It was maybe too short here. It's also visualized in this graph. So it went up a little bit, but didn't reach the upper limit of the part that we were in. And yes, we want to measure the zinc in all the trials. So before the start of treatment and while. Yeah. Where is it? Here. I think.
Sorry, just one.
It's orange. Oops, sorry. It's orange, and you'll find it here.
Okay, so this is actually the slide that I was going to reference because I was going to apologize if I missed something, but I was wondering if after the after effects of everything with the zinc, if there was any correlation, because as soon as I hear like ferritin, iron, things like that, I think as a parent, I think of the constipation issues. Was that ever looked at as far as a correlation between the zinc and bowel?
In this patient, it wasn't reported before he didn't have any problems with constipation. So afterwards, the parents also didn't report any of this. It's addressed in the zinc trial in the diary if there are any problems, and Vladimir's taking the stool samples. So we'll see.
Thank you, Moritz.